Good morning. I'm Dr. Mona. Can I examine you? Start your examination by inspecting the upper limb for the presence of scars, deformity, any wasting or fasciculation by tapping over the muscles. Ask about pain and start testing the tone. Any pain? Okay, I'm going to move your limb. If you feel any pain, please tell me. Start tone by checking for circumduction of the shoulder. Flexion, extension of the elbow. Then circumduction of the wrist. By this, we check the tone around the shoulder, elbow, and wrist. Then, moving to the power. Check the power of the shoulder joint. Flexion, push me up. Push me down, please. Push me up. Push me down. Abduction, push me out. And adduction, push me in. Thank you. Power around the elbow, tested by flexion, push me in, push me out. And extension of the elbow. Push me in, out please. Then power around the wrist by checking flexion and extension of the wrist. Close your fist, push me down, up. Down please, up please. Checking the hand grip for delayed relaxation of hand grip to diagnose myotonia if it is present. Would you release your head? After this, moving to the next part of our examination, which is reflexes. Biceps, brachioradialis, and triceps reflex. I'm going to tap over your tendon. It will not hurt you. Put the upper limb in 120 degree. Press over the biceps tendon. Look to the muscle and tap. Same here, 120 degree. Expose the muscle. Press over the tendon and tap. Brachioradialis tested also in 120 degree by putting fingers over the brachioradialis tendon and checking the reflex. Triceps on 90 degree. Support by the wrist. Support the wrist. Check for the triceps reflex. After you finish the reflexes, check for Hoffman sign, which is the surest clinical sign of upper motor neuron lesion in the upper limb. If it is positive, there will be flexion of the index and thumb on nipping of the middle finger. Thank you. After this, you have to test for cerebellar function. It is tested by either finger to nose, finger to finger, finger to doctor test. So I'm going to check for finger to doctor. Please touch my finger with yours. Then touch your nose. Okay, the other hand. Touch your nose. Would you please touch your fingers together? Again with closed eye. Thank you. Moving to the third part of our examination, which is checking the sensation. We start by fine touch. Can you feel?
Yes.
Same?
Yes.
Would you close your eye, please? Can you feel?
Yes.
Same as above? Yes?
Yes.
Can you feel?
Yes.
Okay. Same?
Yes.
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 Okay, thank you. Checking for pinprick sensation. Can you feel this?
Yes.
Yes. Can you feel this prick?
Yes.
Yes. Would you close your eye, please? Can you feel this?
Yes.
Same like above? Yes.
Yes.
Can you feel this?
Yes.
Same?
Yes.
Can you feel this?
Yes.
Same?
Yes.
Same?
Yes.
Thank you. Then the deep sensation checked by vibration sense and joint position. Activate the tuning fork. Can you feel this?
Yes.
Is it vibration?
Yes.
Same?
Yes.
Okay, close your eye. Start by the base of the thumb.
Yes.
The same like above?
Yes.
Close your eye.
Yes.
Same like above?
Yes.
Okay. If you couldn't feel the vibration, you start moving the tuning fork from the base of the thumb styloid process, olecranon, acromion, clavicle, mastoid till he feels. Lastly is joint position. Demonstrate first the position of his joint. This is up, this is down. Would you please close your eye? Where it is? Down, yes.
Yes.
Up or down?
Down.
Perfect. This is up and this is down.
Testing the higher functions of his brain, the first thing we will do is to test the language. We'll see how fluent he in his language. Can you say something? The weather is beautiful today. Good. And now, what's the name of this thing on your hand? This is a watch. And what about this one here?
This is a push, a button.
A button. And what's the name of this?
This is a thumb.
This is thumb. Great. Now, can you repeat after me? The sun is bright today.
The sun is bright today.
Fantastic. Now, I'll give you something to read, and then you will read one sentence from this book.
The fire matter is a very thin, transparent membrane.
Good. And I'll give you a piece of paper, and please write for me a sentence there. Thank you. Now, the last thing about the language is to see his reception and his production, i.e. expression, which we really tested when we're doing all of these tests on the language, because we asked him a question and he understood what we meant, and then he gave a proper answer. That is the expression, so there is no point in repeating it. But if we would repeat it, I will do. What's your name?
My name is Muhammad.
So he understood that we were asking him about his name, and then he gave us the right answer. Thank you. Now we'll test other component of higher function, which is memory. I will ask him about immediate memory, things that he, about things he did today. So what time did you wake up this morning? 7:30. And what did you have for lunch yesterday? Where were you last Friday?
I was in our farm.
You were in our farm. That's good. So we tested the immediate memory and the remote memory. I'll give you a number, and I want you to remember it, and then I will ask you to tell me what was that number. It's a telephone number, 553-2760. Can you repeat it for me?
553-2760.
Great. And I'll ask you about what is the National Day of Jordan?
It's on the 25th of May,
1946. Great. And then what was the day of your birth?
31st of January, 1993.
Great. Third component of the higher functions, we'll ask about the orientation. I will ask him, do you know who I am?
Yes, you're Dr. Walid.
Okay. And where are we now?
In the clinic.
In the clinic. And what's the time?
It's 9:30.
9:30. Now, the last item to be tested in the higher mental functions would be the few other cognitive functions, like calculations, for example. Can you tell me what's 5 by 5?
25.
Okay, what's 10 plus 10 plus 13? 33. Great. Now, can you do for me 100 and take out of it 7 at a time and go backwards?
Okay, 100, 93, 86, 79, 72.
Now, I'll give you a few things, and you tell me what's the odd one out. A door, a window, a floor, and an apple. An apple. Why? Great. Now we will test his reasoning. I will ask him something and ask him why this is what it is. During the day when the sun is shining and bright, which is longer, your shadow at midday or in the afternoon?
In the afternoon.
Why?
The sun is not right above me, it's to the side, so the shadow is down.
Thank you. And we know we have to check or look at his personality and behavior, as I can see that his behavior is quite good, and he's reasonable and collected. To start with, we have to assess the level of consciousness. This is done through measuring 3 components, one to do with the eye opening, the other one is the verbal response, the third is the motor response. A normal person, awake person, would score 15 out of 15. The lowest score you would get is 3 out of 15. In matter of fact, a dead person would score 3 out of 15. Now we will see how we can get all the components and measure his level of consciousness. We will try to test the 3 components now. We can see that his eyes are open, so we'll give him spontaneously, so we'll give him 4 marks for that. And then we will ask him a question, and we will see what sort of response he will give us. What's your height in centimeters?
185 centimeters.
185, so that's an appropriate response, so he gets a full mark, 5 marks for that. And then we will try to ask him to do a motor function and see what he can do. Can you make a fist and put your hand in front of your face? Okay, great. So he gets 6 for that. So 6, 5, and 4 makes 15. So he's 15 over 15 on the Glasgow Coma scale.
Walid, support the elbow and just passively move the fingers. Passively move the wrist. Passively move the elbow. And passively move the shoulder. Remember, I'll be watching you. You should be doing both sides. You lose points because you do only one side and you forget about it. So you have to do the other side also. Support the elbow. Passively move the fingers. Passively move the wrist. Passively. Tell the patient, relax please. Passively move the wrist, elbow, and put the shoulder through a moderate range of movement. Same thing on the leg. But I have to go a little back, please. Can you go? Have to go further back.
There's a laptop.
Oh, I'm easy, my laptop.
Oh.
Passively move the knee. It's all shown there. Just look at the pictures. And again to the other side. Passively. You don't do anything, I just do it. Just see whether there's any excess resistance or excess mobility. If there is decreased tone, it'll be like a rag doll. It'll be like a rag doll. Another way to do it is to hold both the wrists up and just let the wrists fall down. See? This is normal. If there is decreased tone, that side wrist will be lower down. And move the joints and see. It's normal. So this is tone. Examination of tone of the upper limb, examination of tone of the lower limb. Let's start with the upper limb. Start.
0.
You have to do the shoulder, you have to do the elbow, you have to do the wrist, and you have to do the fingers. So shoulder strength, bicep strength, tricep strength, wrist, dorsiflexion, grip strength. Then I'm going to demonstrate on the leg. So please extend your hand against my resistance. No, give resistance. This is how you test for shoulder.
I'm weak, sir.
Good, that's fine, that's fine. So you're tested for deltoid. Similarly, again I'm repeating, don't forget to test the opposite side. Many of you do forget and you lose points. Next, I'll ask you to flex your elbow and I'll give resistance. So flex it tightly.
Oh my god.
Against
I'm getting pulled off the desk.
Against resistance. Now straighten your hand, try to straighten your hand against resistance. Keep it flexed, keep it flexed. Flex it, now try to straighten it. Give resistance. So biceps, triceps. Next, dorsiflexion of the wrist. Look at the picture very carefully. Next slide. Dorsiflexion should be with the hand closed. Why? Because we don't want them to use the extensor digitorum. So the wrist should be in the flex position. And so please make a fist and try to straighten the wrist against resistance. So this test for dorsiflexion of the wrist. So you're supposed to ask the patient to make a fist. Move it up, and don't let me bring you down. This is dorsiflexion of the wrist. So we will watch you whether you ask the patient to make a fist and whether you are giving resistance. Don't keep it open because otherwise he'll use the extensor digitorum also. So here you're testing for the extensor carpi radialis, longus brevis, and ulnaris. Similarly on the other side, please make a fist. Yes, and you try to give resistance. Last one, grip strength. Now watch very carefully. Don't keep your fingers straight next to each other. Why? Sometimes the patient is so strong that they will crush your finger. always keep one finger over the other finger. We will watch this. Please try to hold my fingers as tightly as you can. You can do both simultaneously. And watch for strength. And with your thumb, just keep holding me. With your thumb, try to remove your finger. This is testing for grip strength. Everybody watch me. Okay, slightly separate. Try to bring my hands together. Testing for adduction. Adductors. Okay? Abduction. Try to move my hands out. Abduction. Next, put your hand behind the thigh. Press down on my hand. This is extension of the hip. Gluteus medius and gluteus minimus. This is extension. Flexion. This is, no, iliopsoas. Flexion. You can do both simultaneously. This is the quickest way to do. Next, flexion of the knee. Give resistance. Yes. Patient is trying to flex, I'm trying to extend. Do the same on the opposite side. Resistance. Now try to straighten your knee. Straighten it, try to straighten it, straighten your knee. Yes. Give resistance. Straighten. This is extension. So flexion, extension, both sides. Next, try to put your foot up. Give resistance. L5. Try to do only with the great toe. L5. Push down my hand. S1. Just the great toe. S2. So we have tested for all the muscles. So let's start with the ramp. Rapid alternating. Can you do this on one arm? Moderately fast.
Maybe not.
Okay. Can you do it the other way? So
This was definitely faster
so
than
the
that.
absence of this is called dysdiadochokinesia. You know that. This is an example of a RAM, rapidly alternating movement test. There's another one for this. You can do it on this also.
So this side's slower than this side. Oh, that's
Doesn't
really
matter.
Yeah, it's slow.
This is rapidly alternating movement. It's shown there. There is yet one more way of doing it.
That's weird. Is it the normal side?
There is yet one more way of doing it. Ask the patient to tap his or her thumb with the index finger. It's shown there in that picture, in the lower picture. Ask the patient to tap his or her thumb. So these are the two ramps for the upper limb. Now let's do the ramp for the lower limb. No, you can keep your leg hanging now. Ask the patient to tap your hand with his foot. You can do it simultaneously. Please, no. Tap my, here.
Good job, Abid.
So this is the ramp for the leg. Rapid alternating movements. With the leg, first you show the patient. This is the simple heel shin test, which all of you know. First, demonstrate to the patient. What I'd like you to do is, with your heel, start from your knee and go all the way down to your ankle. Similarly, the other side, with your heel, go all the way. First, show him. Next, ask him to close his eyes and do it. Can you close your eyes and do it, please? Yes. The other leg. This is it. If the person has got a cerebellar problem, the person will do all those funny things and may try to look where he is doing and all those things. So you asked him to do it once, he got the hang of it, then he should do it, both sides. So this is the heel shin test. Next slide, please. The gait. I can use you for the gait. Come. Would you like to walk this way or this way? Just walk normally. Go all the way up to the whiteboard and come back to me. Yeah, thank God she can do this one. This is the catwalk, isn't it? Okay.
No, I'm not, I can do that. I'm walking normally.
Yeah. Just walk. Go all the way to a particular distance and then turn. So watch for the stance, the gait, the movement, the rhythm, the equilibrium, the hand motion, everything. It's just a standard walking, how the person turns, whether the person turns in one shot or whether the person turns in multiple blocks. Because I will be teaching all those things in Parkinson. They will have what is called block turn, stance and all those things. They'll have magnetic gait and all those things. So her gait is fine. The next one will be tandem gait or heel to toe walking like you do when you're being tested for alcohol by the police, isn't it? So this is a straight line. So you have to walk in a straight line. Heel. You can walk up and down.
My socks are.
Okay, just doesn't matter. Walk on your heel and then turn around and walk on your toes. This walking on heel.
Look at we're in stilettos.
Yes. So this is heel walk and toe walk.
Penguin.
In corticospinal tract lesion also they will have difficulty in heel walking. It also tests for cerebellum. Next one, I think I'll use him. That is you have to hop in one place, first with one leg and then the other leg. Hop in one place.
I know.
Then with the other leg. And then with both the legs, shallow.
Appreciate that.
So this tests for both proximal and distal muscles. Heel walking and toe walking tested only the distal musculature. The next one, I'll ask you to do that. And that is shallow knee bends. First with one leg, shallow knee bends. And then with the other leg, shallow knee bends. Patient's eyes, legs together, both the hands, palm up, keep it up, and eyes closed. And watch for two things. Please do that. Palm up, eyes closed for about 20 to 30 seconds. What do we look for? First thing, whether the hand remains steady in its place or not. What is this pronator drift? If there's a corticospinal tract lesion on his left side, let's say, left corticospinal tract, his right hand will do something. Or if he's got a cerebellar lesion on the right side, his right hand will do something. What will it do? I'll show you. You can open the eyes so that you can see. Suppose I have a lesion on my corticospinal tract on the left side or my cerebellum on the right side. When I'm asked to do this, my hand will slowly pronate. And it may even flex at the wrist and at the elbow, and it will drift away. This is called pronator drift. So this I'm just showing you. So when you ask the person to do the same thing, hand is like this. The next component of the test is written in the last paragraph there, is you gently tap the hand down. Both the hands. You'll find that in a normal person, it swings back again. Keep your eyes closed. If you do that, because the hand has got a certain amount of tone, and it is remaining like that, it will come back to its automatic position. On the other hand, if it's a cerebellar lesion, the hand will bounce, and it will do all sorts of funny things. So this is the second component of the pronator drift. So we have done the stance. What is? Again, we will do it on both the sides. Don't forget. First, you'll have to demonstrate to the patient what exactly you are doing. You have to explain. So, you want Mr. Dabaja? Yes. Mr. Dabaja, what I'm going to do is, please look carefully. When you feel your great toe going up, you will say it's up. No, not now. I'm just telling you what I'm going to do. This is, when it is here, you'll say it is down. When it here, it's out. And when I do like this, you'll say it's going around. Next point. Separate the great toe away from the other toes. Why? Because he should not get the feeling from the other toes and tell you what his position is. I'll be watching this. Move the great toe away from the other toes. Demonstrate to him what you are going to do. And then, please close your eyes, Mr. Dabaja. What is the position of your great toe?
Up.
Wonderful. What is the position of your great toe?
Down.
What is the position now?
Going around.
Going around. So this is how you do. If you let it touch the other toes, I deduct points. Because when you touch the other toes, he will use the sensation of the other toes to tell you his position, right? So I'll watch whether you have removed it from the other toes, whether you have clearly explained to the patient. And again, patient's eyes should be closed. Don't forget, you lose points on that. You forget to tell the patient to close his or her eyes. And again, do it on the other side corresponding. You forget to do that, again you lose points. So, please close your eyes. Which is the position of your great toe?
Down.
Which is the position of your great toe?
Up.
What is the position now?
Around.
So this is how you test for joint position sense. Both the sides, eyes closed, up. All of you know stereognosis. Give a readily identifiable object to the person. Can you close your eyes? Tell me, hold this, and tell me what is this. Now, what you can do is, this is one of the videos which I did last semester, give a series of very similar, a little different items. Let's give me these and one pencil. Now, with your eyes closed, I've got a few other objects here. With your other hand, pick these objects one by one and tell me which one matches the object in your right hand. I'm testing the stereognosis by using the corpus callosum.
Tell us what color.
That is synesthesia.
See if it's a mechanical pencil or not. This one.
Oh, See? So
Good job, good job.
This is, I have gone one step beyond stereognosis. First, she identified this with her eyes closed, so that was stereognosis. And then I used her corpus callosum to match this with that. So we did two. We have extended the test of stereognosis. You have to give a familiar object. You should not give a strange object. So it's a coin or a key or a pencil or something which the person uses daily. And you should allow the person to move that object in his or her hand. They cannot just touch it. They should be allowed to move it in their hand, because stereognosis is a complex, it's a cortical sensation. It's a combination of touch, pressure, and conscious proprioception. So all these things together will be integrated in the cortex. Remember, primary sensory cortex and the superior parietal region and inferior parietal lobule. Next one, number identification. Close your eyes, please. If the person has got, let's say, I'm going to do the next one again, then I'm going to do the next one. If the person has got, let's say, she has got arthritis, rheumatoid arthritis, or she has got some injuries in her hand, or she cannot move her fingers, or something like that. Does that mean that you will not do stereognosis? We have other methods of doing it, right? What will we do? We will do the usual old-fashioned method. We will write, I did this in the classroom. You write a familiar letter on the palm of the hand and ask the person to identify it. Again, don't forget to do it on the other side. Don't forget to tell the patient to close his eyes. I'll be watching for these things. So we did. So if you can do stereognosis, you can do graphesthesia.
So you
or you
write
can
the
do
same
both.
thing on both hands.
You can write another one also. You can write something which you know the person is familiar with. So I know he's a highly educated and a highly intelligent man, so he does know what is 3, and he does know what is A, so he will definitely be able to identify it. So this is graphesthesia, and you know this is a cortical sensation. The next one, 2-point tactile discrimination. I don't have the object, but you will be given a pin. You will be given a pin. So the 2 points of the pin, you have to do it again with the eyes closed. You have to do it on the palm of the finger. So you can touch the 2 points of the finger and ask the person whether he or she can feel the 2 points separately or not. So this is 2-point tactile discrimination. Again, do it on the same side, opposite side, corresponding areas. Normally, if the pulp of the finger is the most sensitive, they can identify 2 separate as even less than 5 millimeters. On the flexor aspect, it becomes a little less sensitive, but it is still sensitive. On the extensor aspect and on the back, it is very insensitive. They cannot identify anything closer than 3 centimeters. Finger, 5 millimeters. This is 2-point discrimination. Next slide, please. So it's all. There are 2 related tests, you will be doing them. One is called point localization, and the other is called tactile extinction. We touch him on one particular place in the hand and ask him, where did I touch you? Where did I touch you? Show me, please. You can open your eyes and show me. Okay. Similarly, do it on the other side. Close your eyes, please, Mr. Tabaja. Show me where I touched you. Now you can open your eyes and show me where I touched you. So this is point localization. And an extended version of that, which is used for the trunk and for the lower limbs. Can you sit down, please, Mr. Tabaja? You have to keep saying it so that he knows that you are, you're sort of, that's how you build a rapport. 2 is hypo and 0 is absent. You have to know the grading of reflexes, deep tendon reflexes. So that's about the knee hammer, how to hold the knee hammer. Again, we'll have to do the reflexes. Next slide, please. Upper limb, the 3 reflexes that we will be doing. I'm going to demonstrate the upper limb, I'm going to demonstrate the lower limb. The 3 reflexes that we'll be doing will be the biceps, the triceps, the brachioradialis. So let's start with the biceps. Before that, when do we use the pointed end, when do we use the broad end? There's some simple rules of thumb. If the tendon is narrow, use the broad end. The 2 examples where we use the broad end is brachioradialis and the tendocalcaneus, tendoachilles, because the tendons are narrow. If you use the narrow end, you're likely to miss it. That's why you use the broad end. Biceps is also a narrow tendon, but biceps is the only exception where you don't tap on the tendon directly. You keep your thumb on it, and we'll be watching that. Biceps, there are several ways of doing it. One is in the sitting position. Okay, the patient is sitting. Sanyal. So what I would like you to do is keep your hand very relaxed on my hand. Absolutely. Ask the person to keep the full weight of the hand absolutely relaxed on your own hand. Patient should not be stiff or tense. Relaxed. Feel for the biceps tendon, and you will be able to feel it very easily. You will be able to feel it in the cubital fossa. It's very easy. Once you feel the biceps tendon, give a gentle pressure on the biceps tendon. In fact, if you're right about it, you will feel the pulsations of the brachial artery right medial to that. I can feel it. So the biceps tendon, I've given a little traction. Now what I'm going to do is, because the area is very limited here, I cannot use the broad portion. I have to use the narrow portion, but I have localized it with my thumb. I'm going to tap my thumb with the pointed end of the knee hammer. Are we clear? So this is how we will do. Keep it relaxed, absolutely. Did you watch the muscle contracting? You can stand up, right? So line. Next, the triceps. There are 3 ways of doing it. The nice method is hang the limb out to dry. This is called hanging the limb out to dry, like you're hanging clothes, you know. So I have made her hand hang as if I'm drying it on a clothesline. So keep it relaxed, absolutely. Put the full weight of your hand on my hand. Yes, that is important. And you feel it just above the olecranon process. And you tap this area. There.
Yeah, I see it.
That is the triceps reflex.
Do it again.
There is another
Can
one.
you do it again?
Keep it relaxed. Keep your full weight. Ask the patient to be absolutely relaxed and keep the full weight of his or her hand on your hand. Usually patients will be stiff. You will not get the reflex. Okay, in the exams, even if you don't get the reflex, we are not judging you on that. I'm going to watch your procedure, how you're doing it, whether you're doing it the right way. Keep the full weight of your hand on me. I should be able to feel the weight relaxed.
Oh, yeah.
That is the triceps. That is one way. The other way is if the person is lying down, you can just ask the patient to flex and you can tap there. So that is another way to do it. So patient lying, patient sitting. And the third one is the brachioradialis. Remember I said brachioradialis, the tendon is very narrow. And it is inserted on the radial styloid process. The radial styloid process, you can feel it just above the anatomical snuff box. Remember the anatomical snuff box? Where you take your salt before taking your shot per limb. So feel the radial styloid process first. The brachioradialis is inserted on the radial styloid process. So you have to go approximately 1 inch above that. We have to use the broad end because it's a very narrow. If I try to do it with, I may miss. You see? So I'll use the broad end. So hold the hand in a mid-prone position because this is the position in which the brachioradialis works best. And goes lightly above that and tap. You can see the contraction of the brachioradialis there. That is how you test for brachioradialis. Again, do not forget to do it on the other side. Hold it, support in the mid-prone position, feel the radial styloid process, and tap. That is the brachioradialis tendon reflex. So we have done the 3 reflexes: biceps, triceps, brachioradialis. Next one, please. I'm going to do the knee, ankle. Can you go a little back? One way to do the knee is with the patient sitting. Give a gentle upward, keep it absolutely relaxed. Give a little stretch of the tendon. Give a little stretch of the tendon. And again, this is the place where you use the broad end. Why? Because the tendocalcaneus is pretty narrow. There.
Cool.
Similarly on the other side, don't forget. So we'll watch whether you're using the right side, right end, and whether, again, elicitation is not the important thing. I want to see whether you're doing the procedure correctly or not. Similarly, okay. Again, keep it relaxed, absolutely. Patients will try to tense their limbs, I'm telling you. You have to repeatedly tell them, Mr. Dabaji, to keep your limb relaxed, absolutely relaxed. You give gentle dorsiflexion to make the tendon a little taut. And there. If you do it the right way, you will get it. 100%. It's when people are not giving the proper instruction to the patient, that's why you're not able to elicit it. Suppose the person is lying down. There's another way to do it. Do we have place for you to lie down? Or there's no place for you?
All my stuff.
Or you can just lie down. My God, people bring their whole household here.
That's Chanel.
If the person is lying down, there's another way to do it. Watch it. Okay. Can you cross your leg over the other? Keep it relaxed, absolutely. Cross one leg over the other. Keep it relaxed. Keep it relaxed. Again, give a little dorsiflexion to tauten this tendon. And tap. Keep it relaxed, absolutely.
He's so relaxed. Look at his arm, Abed.
There.
You guys aren't letting him relax.
You can see it contracting.
So what do you look for here?
Well, you're seeing contraction of the
Oh, I didn't see that.
triceps, and the surae. Similarly to the other side, can you cross over? Keep it relaxed, absolutely. Give a little gentle dorsiflexion. You don't do it, I'll do it. Keep it gentle dorsiflexion and tap. Note, I did not use my shoulder or I just used my wrist. It should flow freely. There. That is. Now I'll tell you what is clonus. Clonus is grade 5 reflex. We used to, nowadays they call it clonus. Can you sit down? Suppose the person has got a very exaggerated reflex. Suppose a person has got a very exaggerated, you can hang your leg down. If the person has got a very exaggerated reflex, so exaggerated that even by touching the tendocalcaneus, it moves very briskly, I can elicit something called clonus. And I'll show it to you how to do it. That happens when the person has got a dense corticospinal tract lesion, very high degree of deep tendon reflex. I just rapidly dorsiflex his foot, like this. You keep it relaxed. I just rapidly, even now I elicit it a little bit. I rapidly do it and it'll start flapping a few times. That is called clonus. That is, some books call it grade 5. So this was the tendocalcaneus. Now I'm going to demonstrate the next slide. Oh, it's in here. The knee jerk reflex.
So that's normal when it flaps?
No, it should not. That's exaggerated. Average normal is 2+. 3+ is mild, is brisk. 4 is very brisk, and 5 is clonus.
You're the worst camera guy.
Okay. Knee jerk. Again, the procedure. Watch very carefully. You will have to. I think I'm going to use her for this because I'll show you. This is the place where you might have to do the gender 6 maneuver. What is the gender 6 maneuver? Remember? You have to ask the person to clench. You can see it in the previous slide. There. No, the ones before that. There. The top picture. Hook the fingers, pull them apart, and ask the person to clench his teeth. That way you're increasing the gamma discharge. So we might ask you, okay, let's say this person has got a very weak reflex. How will you exaggerate it? You will ask the person to. So we'll demonstrate both in this now. Okay. So can you hook your fingers, Chanel? Like this. Pull it apart hard and clench your teeth.
Your teeth.
Clench your teeth and pull your fingers apart. Yes. This is the way we have increased the gender 6 maneuver.
Oh, okay.
So, okay, I'm going to tell you when to do that. Now, can I ask you to cross your right leg over your left knee? Yes. First step. Again, tell the patient to relax. Many patients will try to keep it stiff. They are invariably stiff when a doctor is examining them. That's called the white coat syndrome. So, relax. Absolutely relax. The legs should be hanging freely. Now you ask the person to do gender 6 maneuver. Let's assume that she's got a very weak reflex and I want to increase it. Can you do that, please? Feel the the ligamentum patellae between these two bones. Which are the two bones? The patella here and the tibial tuberosity here. The patella here and the tibial tuberosity. Exactly midway between the two is the ligamentum patellae, and that's exactly where we are going to hit. Keep it relaxed, absolutely. Again. Okay, now relax. Release this. So now I've removed the gender 6 maneuver. I'm just demonstrating it to you. Relax. See the difference? It was there, but it was milder. When she did the gender 6, it became exaggerated. Yes? Do the other one side. Can you cross over the other leg, please? Keep it relaxed. Keep it absolutely relaxed. You might have to spend a few seconds to tell the patient. Relax, relax. And when you tell them, they invariably relax. In fact, even now, when I'm saying relax, I can feel her muscles are relaxing. Patients always tend to tense up. Okay. Feel the ligamentum patellae between these two bony prominences. The patella here, tibial tuberosity here. Can all of you see? Okay. You just have to do it once very gently, it will happen. Now please do that, gender 6 maneuver. Of course, patient does not know it's gender 6. You'll have to explain to the patient what it is. Again, feel, keep it relaxed.
Oh my God.
You see visibly how it differs. Gender 6 maneuver does this job. So this is the one.